Well, welcome everybody to today's neurotrauma evidence synthesis training. Today we've got Dr. Brent Masel, who's going to be speaking on traumatic brain injury as a disease process. Dr. Masel is a clinical professor, a medical doctor, and a clinical professor of neurology at the University of Texas Medical Branch. He's the executive vice president for Medical Affairs Center for Neuroskills, and he's currently the national director of the Brain Injury Association of America. And he is extensively published in traumatic brain injury. He's published on all sorts of topics from virtual reality to post-traumatic hypopituitarism. And more recently, well, I shouldn't say more recently, it's been 14 years now, Dr. Masel, since you wrote your paper on traumatic brain injury as a disease process. And more recently, that's been adopted now within the healthcare system. And that's the topic of today's lecture, which is brain injury as a disease as opposed to a discrete injury one-time event. So without further ado, welcome, Dr. Masel, and take it away.
Well, thank you very much. I'm delighted to be here. And good to see my colleagues, Kate Randolph and Rob Dickerman here. And I know it's early in the morning for you on the West Coast, so either turn off your video or button up your bathrobe because I'm sure some of you are already in your pajamas. What we're going to be talking about is looking at brain injury in a different way. And as David said, the paper was written 14 years ago, and then just this past January, the Centers for Disease, CDC said, we're now going to talk about brain injury as a chronic condition, chronic health condition. So it only took 14 years for that to bubble through. Science moves very slowly sometimes. So what we're going to talk about is changing the way brain injury should be viewed. It's not like a broken bone. It's not like you put it in a cast and you give it a month of therapy after that, and then everything's going to be fine. And certainly if you break a bone, it's not going to affect any other organ system in your body. But as we're going to talk about, certainly this is what's happening after somebody has a brain injury. Next slide, please. Okay. We're going to talk about the fact that brain injury is the beginning of a disease process. It never, ever, 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 ever goes away. And as I talk, I want you to think about patients you've encountered or even family members you've encountered with brain injuries and try to put that together with what we're talking about. But here is some definitions from Funk and Wagnalls. Isn't this what a brain injury is? It's ill health, malfunctioning in a living organism. And I will tell you that the initial paper was brain injury as a disease. And as I brought this to the Brain Injury Association, there was some conflict because some people didn't like the idea. It was mostly the brain injury survivors didn't like the idea of having disease tacked on to them. And I can sort of understand. And so we started talking about it as a chronic health condition. So you'll hear me go back and forth, but to me, it's a disease. I have, despite the fact that I'm skinny and run and do all this, I have hypertension. So I got cardiovascular disease. I can, certainly deal with that. All right, next slide, please. So this is the purpose of the presentation. I'm going to be showing you that it is the beginning of a disease process. Next slide, please. Okay. Important to know that neither an acute or a chronic TBI is static, and it needs to be managed and paid for, just like diabetes, just like chronic kidney disease, just like cardiovascular disease. It needs to be paid for and managed, just like those diseases. Next slide, please. Okay, this is a slide from the model health systems in the U.S., and it's not. Everybody should model how they do it. It's a model health system in that these are systems that can follow a patient from ER to home. and I think there's about 15, give or take, in the United States. And they basically collect data. That's really what their main function is. Because when this first started, nobody had any data on brain injury. So they were a data gathering organization. And what they found, and I'll make the numbers easy for you, this is comparing 5-year epochs. Over 15 years, give or take, about a third of the people said they got better, about a third of the people say they stayed the same, and about a third of the people said they got worse. Now, it's not worse at every aspect of their life, but just sort of subjectively, overall, they felt they were doing worse or better or staying the same, which raises the question, why is the third doing better and why is the third doing worse? What's going on? What's the problem? Next slide, please. So this is from the World Health Organization. This is the definition of a chronic disease. I am not going to read this to you. A good presenter should not read their slides to the audience. The assumption is the audience knows how to read. So you can read this, but isn't this what a brain injury is? Okay, next slide, please. All right, so we're going to talk about some of the morbidities and mortality relative to traumatic brain injury. A brain injury is the leading cause of epilepsy in the young adult population. And we know that people with post-traumatic epilepsy have poor outcomes. Now you can see the second line that the numbers are sort of all over the board because that's how the studies have been. What's important relative to this talk is the latency. And the latency from the brain injury to the first seizure can be as long as 17 years. So what has been going on during this period of time? Why is it 15 years later that the patient has their first seizure? We don't know. I just lectured to the neurology residents last week, and nobody asked their patients if they have a history of a brain injury. None, zero. And I am guilty of that frequently as well. And I see a lot of Alzheimer's patients, and I certainly should be asking that, but it has to become ingrained in just part of your natural pattern. And relative to the next slide, patients with epilepsy are 3 times more likely to have stroke. Next slide, please. This is obviously a study out of California, lots and lots of people. And if I were to ask you, for having a stroke as hypertension. So what is it about the brain injury that causes you to have a stroke later on? This is a study that I find fascinating. You can see it's only 3 years following TBI. It was from a large database in Taiwan. There was another study that was done on military, and it also showed an increase in the number of traumatic. Yeah, back up one.
Sorry about
Itchy
that.
finger.
Yep.
Okay. MS. Oops.
Right there.
Anyhow, MS. There we go. And it was the same database as relative to the stroke patients. What is it about MS? We used about neuroinflammation, and I have there was a patient I saw who had a, relatively speaking, mild TBI, who developed like a month later, absolutely positively florid MS. And as we will talk about, and the feeling is that traumatic brain injuries, one of the issues in this chronic condition is neuroinflammation. And so perhaps that's the commonality between MS and TBIs. Next slide, please. I really show you this slide only because I was the lead author on this paper. Sleep issues are common following brain injury. It's common, in people who have not had brain injury. We did a study where we took all comers, and I was running a post-acute brain injury program at the time. And if you say to the potential subjects, and Kate certainly knows this, gee, you want to be part of this study and help mankind, and you want $100? Oh yeah, I'd like to help mankind for $100. So we took all comers. They did a polysomnogram, and the key is after the polysomnogram, they have to stay in their room, and then they take naps. They take 5 naps or 4 naps, depending. And you wake them up when they get down to a certain stage of sleep, and then you measure the time it takes for them to fall asleep. And depending on who's doing it, some people say 5, some people say 10 minutes on average, and some people say, "Man, I can fall asleep just like that," but not 5 times during the day after you've had a normal night's sleep. As normal as it could be when you have all those wires that pass to your head. And what we found out of the 70 people that we studied, give or take, roughly half were absolutely normal. Of that half of the half had either obstructive sleep apnea, periodic leg movement sleep, narcolepsy, and then the other half of the half, so 25% of the people had a normal polysomnogram, yet they were clinically sleepy during the day. And so because their MLS median lead MLST was less than 5 minutes. We had one patient whose it was less than 30 seconds. So she'd fall asleep like with after image of the lights was still in her eyes. And she had no idea at all that she had this problem. And she drives. But that was a long time ago, and I think you all are safe. All right, next slide, please. And go here. And the one thing that we have been learning over the past, did we skip? This is the next slide?
Next slide.
Okay.
Yeah, there you go.
What we've been learning is, and maybe it's a whole other topic, is the lymph system. You have your lymph system that cleans out the garbage in your body. We have the lymph system, which cleans out the garbage in the brain. And the lymph system is most active during the deep stages of sleep. So what we are really learning is why good sleep is so important and sleep hygiene is so important. I see a lot of dementia patients go to bed at a certain time, wake up at a certain time, and now I have some scientific reasoning behind why it is so important. Looking at mortality, the interesting thing about this slide, I find, is that is in red. After a year, you would assume the more severe the injury, the more likely they are to die. Okay, I understand that. That makes perfect sense. But after 1 year, so you've factored out all those other issues that come with the acute injury. After a year, it doesn't make a difference how bad your injury was in terms of statistical mortality. Most of this is moderate severe. The mild TBIs were not part of that original part of the study. But so why is it that 3 years post-injury, it doesn't make a difference if you had a moderate brain injury or a severe brain injury, your odds of living, if you will, are the same. Next slide, please. Okay. Same kind of studies. Absolutely. There is increased mortality associated with traumatic brain injury. And statistically speaking, if someone's brain injury was bad enough that they require to stay in a rehab hospital, their life expectancy,
sorry.
That's okay. Their life expectancy is reduced by 7 to 7.5 years. And the first time I ever gave this talk, it was to a bunch of brain injury survivors with the Brain Injury Association of Texas. And I quoted that statistic. And in my mind's eye, afterwards, a little old man came up to me shaking. And again, that's probably how I made that up in my brain. And he said, "Does this mean I'm going to die 7.5 years sooner?" And that's when I realized we present statistics to patients all wrong. And so I always give the caveat when I'm talking to people with injuries that this is statistical. It doesn't mean it's going to happen. It is a statistical thing. If the surgeon says you can have the surgery only out of 1 out of 1 million dies, it doesn't mean everybody dies 1 millionth. It means one person dies 100%. So I try to make sure that the patients understand the statistics, because we physicians do a horrible job presenting that kind of information. All right, next slide, please. Okay. Generally speaking, infections are the bad boys here. That's what happens. Seizures is a big issue. A lot of patients get lost in the system. Can happen relative to seizures is called SUDEP, sudden unexplained death in epilepsy. Usually these are the individuals with poorly controlled seizures on multiple medications, and the feeling is they have seizures in the middle of the night, and the outpouring of catecholamines, and they have an MI, and they die. It's a real deal. And I've had patients that died from SUDEP. Next slide, please. Okay. Mortality, here you go. It's neurodegenerative disease. I wrote a paper, we just finished it, looking at stroke as a disease. And same kind of thing. There's a connection between brain injury and stroke, and there certainly is a connection between stroke and the development of neurodegenerative disease. And this is a study looking at mild TBI. And the patients with the mild TBI will tell you that there's nothing necessarily mild about the TBI. Mild only refers to the mechanism of the injury. It doesn't refer to the outcome, which is ultimately what is the most important thing that we do in our day-to-day jobs. It's about the outcome. So what is it about a mild TBI that will increase your mortality? I don't know. Next slide, please. Psychiatric disease, huge issue in the United States. I rounded out the numbers here. You can see it there. The entire population of Denmark was studied, and patients had twice the suicide risk if they had a history of a traumatic brain injury. Next slide, please. I can understand having a change in personality after a TBI. Makes perfect sense. But half these people studied developed a major mental disorder after their brain injury. Psychosis, schizophrenia, manic depressive illness, major depressive disorder after their TBI. And I will tell you, I had a patient he had a company that tunneled under highways to run cables. He had maybe 8-10 workers. He had a mild, moderate TBI, and was able to go back to running his company. And then 6 months, a year later, I don't really remember, he just got bananas. I mean, he just got absolutely crazy. There were microwaves coming from the Denny's restaurant, half a mile away. I mean, absolutely crazy. So he was fine after his brain injury and then became psychotic. And there was no history of psychosis in the family, so you can't even blame that. What was it about the brain injury that caused him to become psychotic? No idea. Next slide, please. All right. There is no Bible in medicine. Doesn't exist. And anybody who has done a book chapter knows you write or done a book, that you do your chapter, whatever it is, and then you send it in, and then nothing happens for 6 months or so, and then you get something back and says you gotta take a look at this and send it back to us in 24 hours. And then you send it back and then nothing happens and they send it back. Bottom line is it takes you about 2 years for the medical book to be published. So whatever's published is out of date right then and there. We have the Institute of Medicine is now called, has a much longer acronym now. If a person in Congress wants to know about the incidence of gallbladder disease in left-handed blonde females, if they can get the money, then they go to the Institute of Medicine, and the Institute of Medicine brings in the smartest people in the room, and they don't do the basic research. They basically do reviews and come out with an opinion. And it's either a white paper or a book. And this was in 2009. It was the Gulf War in Health. Interesting, it had nothing to do with anything but brain injury. But politically, at the beginning of the wars, nobody wanted to talk about brain injury in the military, and then it became obvious that this was a major deal. And so you can download this whole thing online if you wish, and you can see what they said here at Relative Psychosis, and we'll talk about some of their other opinions. That the brain injury does not necessarily produce the psychosis right away. It comes later on, like the guy that I had as a patient. Okay, next slide, please. And again, dementia. There's very little doubt about it that this is brain injury is a major cause of leads to the development of Alzheimer's type dementia. Next slide, please. And the worse the worse the injury, the more likely it's going to happen. This was a study on vets, and like a lot of the studies that are done on vets, they are not necessarily all military type injuries. A lot of them are civilian type of injuries, auto accidents and such. I read the bottom one, this study by Barnes. It was in USA Today. I was traveling and I picked up a USA Today, and that's where I saw it. And it got a lot of people's attention because at the time, mild TBI really wasn't talked about. When I started in brain injury was an orphan disease. Nobody even talked about it. I mean, it just didn't exist. And mild TBI really, until the wars and the NFL, was the same thing. Nobody cared about it. Nobody talked about it. And obviously now they do. And this got the attention of a lot of people. Next slide, please. And even if cognitively they're okay, after their injury, later on, they have an increased incidence of dementia. Next slide, please. Parkinson's, same thing. We feel Parkinson's is a neurodegenerative disease, and maybe neuroinflammation is involved, and you have an increased chance of developing Parkinson's disease. CTE, we used to call it dementia pugilistica because it was only in the prize fighters. Now we know that's not necessarily that case. CTE can only be diagnosed post-mortem. It is a pathologic diagnosis. Until that time, they have what's called traumatic encephalopathy syndrome. And it's horrible. It is horrible. I rarely watch football anymore because I've seen what it does to the people. I had a patient, I will tell you a story. He was mid-60s guy, and had a company that ran cables in office buildings, had half dozen employees, and he was starting to get a little weird, and I just thought he was depressed, and he was depressed, and put him on an antidepressant, and he got better for a while, and then his memory got worse, and he started acting weirder and weirder, and I was talking to his wife, and the wife said to me, well, before he did this, he was a rodeo clown. So he was one of those guys that got in the barrel to distract the bull, and God knows how many times he got banged on the head, hundreds. And he's in the Hall of Fame, so he was very, very famous, and it was just horrible watching him die. It was one of in medicine, you try not to get too close to your patients because it hurts, especially in my field, because it hurts too much when they deteriorate so badly. And I got close to the wife, and this guy was a stud. He was famous, and he just ended up bedridden, incontinent. It was horrible. So I don't watch football anymore. All right, next slide, please. Interestingly, we would assume after the brain injury, things start getting better. That's what we tell people, but it's not necessarily the case. And this was a Canadian study, looking at DTI, showing the white matter, and showed that the white matter changes continued 30 months into the post-injury. Now, some people will say, well, maybe that was the recovery, man. Maybe it was the brain rewiring itself. Certainly possible. But nevertheless, we're still seeing changes in the white matter 30 months post-injury. Next slide, please. Okay. I've already talked about this. This was interesting. This was a large study, and most of the people were amateurs, and most of them were just high school football players. And the ones playing, and they had a much greater chance of developing Parkinson's disease. In my day, if you were 150 pounds, you were big, and now 150 pounds, you won't be able to carry the water. Now these kids are, 200, 250 pounds. Next slide, please. This, again, another study. It's not just NFL football, other sports. There was only one woman in this study, but they did autopsies on these people who died, and half of them 63 were diagnosed with chronic traumatic encephalopathy. I know for our person in Toronto, I think hockey. I'm from Chicago, so I followed hockey a lot when I was a kid. That's tough on your brain as well. Next slide, please. Okay. What they found in this study, same kind of stuff. This is Dr. McKee, who's one of the groundbreakers relative to this whole issue of chronic traumatic encephalopathy. A lot of suicides. And what they found was a lot of, at the bottom here, 60% of those who had the repetitive head injuries did not have CTE on autopsy, yet they still had a lot of the symptoms of traumatic encephalopathy syndrome. So that you would have guessed that they were going to be have CTE on autopsy, but they didn't. So lots, and maybe these were subclinical, microscopic changes in the brain. We don't know. Next slide, please. Okay, so what do you do? Hey, I do risk-taking behaviors. I climb mountains. I snow ski. I do all that kind of stuff. All you can do is try to make it as safe as you can for your child and for yourself. Certainly wear a helmet when you're going to go bicycle ride, for goodness sakes. Wear a helmet when you snow ski. Do the best you can to protect your brain. And try to get that to help your kids as well. I just read a study, the Guardian helmet thing they put on, it's like padding that really it has not made a significant change in the incidence of concussions following in football. Next slide, please. So we got more to do. Okay, so I'm going to switch gears a little bit and talk about endocrine dysfunction and let you know that hormones are really important here. Next slide, please. So we got involved with looking at hormone dysfunction. I think we published our first paper like 21, 22 years ago. Bottom line is what we found, and this is moderate to severe, because again, most of the work done initially in brain injury was moderate to severe, that roughly 30% of individuals with a moderate to severe injury will develop pituitary dysfunction. And just because you're normal at 3 months doesn't mean you're going to be normal the rest of your life. And some people will develop this problem later on. Next slide, please. And this is a study, Italian study. A lot of these studies were done in Italy. And if you've ever been to Italy, you can understand why they have a lot of brain injuries, because you have cars going this way, motorcycles going in between, and it used to be a donkey cart path. So there's a lot of auto accidents. But this is 5 years post-injury. And what they found is significant percent of people, roughly 50%, had some sort of pituitary dysfunction. And you'll see on the right where it says severe growth hormone deficiency, partial growth hormone deficiency. A lot of disagreement in the endocrine community about exactly what the cutoff should be. It changes with weight, and then I'll make up a number. If 3 is the cutoff, well, what if you're 3.1? Maybe you would benefit from growth hormone replacement. If you're 2.9, what does that mean? And so we get, unfortunately, and a lot of it is driven by insurance, uh, so that I think a lot of patients get the short end here because we say, well, you were 3.1, you're fine. Well, you're not fine, it's 3.1. So that's what the severe and partial is about. Next slide, please. Growth hormone is the bad boy here. Unfortunately, growth hormone has a bad name because it's not just about being tall. We need growth hormone for the rest of our life. And this was a study showing what happens to people with moderate to severe injuries, um, and the problems that they have later on down the line. And I think one of the most important things here is the decreased cognitive functioning. So roughly 20% of those folks are going to develop growth hormone deficiency. Next slide, please. Thyroid is common, it's ubiquitous, especially among the females. It is easy to test for. Growth hormone is a little more complicated. We'll talk about that. But testing somebody for hypothyroidism is easy to do. It's inexpensive, and replacement is inexpensive as well. There's an increased incidence of thyroid dysfunction after traumatic brain injury. Next slide. And of course, gonadal dysfunction. After any polytrauma, women will frequently not menstruate for a while. I think that's sort of Mother Nature's way of saying, you're not ready to carry a baby. But you can see the symptoms that people will have with gonadal hormone dysfunction. And in the males, there's decreased libido, muscle mass, decreased strength. And there is some correlation between a low free testosterone and cognitive function, which goes to show that many men think with their penis, and I will leave it at that. Sometimes it gets a laugh, sometimes it doesn't. I know Rob's like that. Okay, good. I got one laugh. All right. And gonadal hormone dysfunction in the children, because children get lost in the shuffle of brain injury. There's an increased incidence of precocious puberty, which will be the next slide. When I started, brain injury was an orphan disease, and pediatric brain injury is the orphan of the orphan of the orphan. Kids with brain injuries just get lost in the shuffle. They are put in, the insurance companies don't want to pay for them. They get put in special education classes with children whose problems are so significantly different than theirs. And interestingly, children with brain injury may appear okay at first, but all the social skills and all the other issues that they are supposed to accumulate so they can become more mature, they get behind. And so the expression is the kids grow into their brain injury. And children with brain injury just become adults with brain injury, but with even more problems. But this is precocious puberty relative to hormonal dysfunction in the children. The women, the young girls, they develop their secondary sexual characteristics, so they develop big breasts. They look, they may be 12 but look 18, and so they're absolute prey for sexual predators, and they have a greater risk for breast cancer. And in males, they have a problem with aggressiveness, and we see a lot of aggressiveness following traumatic brain injuries anyway. So it's a double whammy. Next slide, please. You can see the problems that they develop, and again, they just get lost in the shuffle, absolutely positively. Next slide, please. Okay, so these are the tests that can be ordered by any physician. Simple, relatively inexpensive. Relative to growth hormone comes out in discrete pulses, predominantly during slow wave sleep. It has a half-life of 18-20 minutes. So I could draw a growth hormone level on Davis right now and then draw another one 2 hours later, and it may show something entirely different. So you can't just do a random growth hormone level. We have something that's called the IGF-1, insulin-like growth factor 1. It's not insulin, it just chemically sort of looks like insulin. And it's sort of an average. It's sort of like your hemoglobin A1C. But hemoglobin A1C is pretty good at detecting diabetes. IGF-1, it's decent screen, but not really a great screen. And we certainly have had many patients who were further tested and found to be growth hormone deficient who had an okay IGF-1 or a non-specific, maybe a little bit low. So if they need, if your suspicion is high that this patient may have growth hormone deficiency, they need to be referred to an endocrinologist for a definitive test. And one of the common ones is the glucagon stimulation test, where you inject glucagon, makes your blood sugar go way up, and then your blood sugar goes way down. And when it goes down, your brain puts out growth hormone, and it's measured over time. It's a 4-hour process. It takes up half the day. Some people get nauseated from the glucagon. We're still looking for a good test that would be so much easier to do. Next slide, please. Okay, and then the glucagon GA stimulation test. There's some others as well, but they all basically, the process is about the same. It's a half a day if you're lucky, and certainly Davis and Kevin can talk more about that if they wish. Next slide, please. All right, I hated biochemistry. I despised biochemistry, and somehow I've gotten right back into the middle of it. So I guess the answer is you need to learn the stuff even if you don't like it. Very basically, we are made up of amino acids. If you had bacon and eggs this morning, you had amino acids, and you have the essential amino acids, which you have to eat. That's the only way you can get them in you. And then there are non-essential amino acids, and there's about 10 and 10. There's a debate about one of them. Non-essentials, your body can take this carbon chain and this hydrogen and basically make the non-essential amino acids. They are the building blocks. That's what we are made of. And in our world, the bottom line, they are the precursor to the neurotransmitters. Okay, next slide, please. So this is an Italian study, and Dr. Ickerman is he and I both know this study, and he's trying to replicate it. We're trying to get the money, quite frankly, so we can replicate this and take it several steps further. But what they found was a month and a half post-injury, lots of amino acid abnormalities, and then they tested them at 3.5 months. Same kind of thing, but still they had NG tubes and IVs, and maybe it was the lack of nutrition. Next slide, please. So we did a study, and it was 6 guys, because guys are the ones that do the stupid things and have the brain injuries. And we measured their baseline amino acid levels, and gave them an amino acid supplement, which was about the same composition as the amino acids composition of your short chain fatty acid in your muscle. And then we measured it again. So baseline, take a supplement, draw your blood again. Next slide, please. And what we found was baseline, the folks with the brain injuries had lower essential amino acid levels. And it looked like valine was the bad issue. And even after we supplemented, we never got the folks with the brain injury up. So even after supplementation, they never caught up to the normal controls. And then we were going to do a further study on this. And then Galveston Island got hit by Hurricane Ike, and I had about 2.5 feet of water in 3 feet of water in my office. And so everything was put on hold, and our main researcher couldn't decide if she wanted to either stay in Galveston or move back to Norway, and couldn't make a decision. And ultimately she decided to move to Arkansas. And so it just sort of languished for a while. And then, next slide, please. And then I said, well, we have a long-term living program. So these people with chronic brain injuries have to live in a communal environment. They can't live independently. And these are people, 20 years post-injury. Let's test them. And then that removes the factor of spontaneous recovery. So I'm trying to make this easy for you. Group A, you can see the dark, I guess the darkest blue or whatever, and then the green. Bottom line is the folks with the brain injury were low. And what we did was, I was a control. We all fasted. We all had our blood drawn. We all ate breakfast, give or take. We all had the same breakfast. And then we measured it again. Okay. And what we found was the people with the brain injuries were lower in their essential amino acids than the controls, and they never caught up. So what happened to the bacon and eggs? Where did it go? And somebody in our group, I think it was Dr. Moore, said, because we talked about, well, could it be sequestered in the liver? Well, that didn't make any sense. And then somebody said, well, maybe it's the microbiome. Maybe we are not absorbing it. Next slide, please. All right, and this is going to show, whoops, that fell apart. The bottom line is that this obviously didn't transfer well, that the controls increased their essential amino acids after they ate. The brain injury group did not. So again, where did it all go? Next slide, please. And this is a study that we did. Although our statistician said, yeah, you got enough, this is great, you can publish it. I said, nobody's going to believe a study on 10 people with brain injuries. I mean, just nobody's going to believe that this was the real deal. So we replicated the study at the Center for Neuroskills, where I now work, in Bakersfield, and we found the exact same thing. In fact, one of the essential amino acids went down after they eat, but I think it's Californian kale and all that stuff that they eat. But same kind of finding. So it is the real deal. Next slide, please. Okay. Which led to us looking at something that's called brain injury associated fatigue and altered cognition. And this are generally the people with the mild TBI. So this is where a lot of our research group is working right now in this area. And it's profound fatigue. It's not, gee, I'm a little tired. It's profound fatigue. It's no matter how much you sleep, how much time you spend in your easy chair, you are still tired. And you have the quote unquote brain fog. I used to run marathons, and to me, that's how I equated it. After a marathon, I didn't want to blink my eyes, like nothing. I just didn't want to breathe. I was so tired. And that's the kind of fatigue that these folks have. And they have an abnormal response to growth hormones, to stimulation for growth hormone. And what we have found is after about 3 months, the fatigue gets better. It takes a while. You need to ramp up the dose. Every endocrinologist does it a little differently. You need to get them to their peak dose. And it takes a while for that fatigue to get better, and even longer for the cognitive issues to get better. And then they stop, and it sort of reverses itself. And the good thing is that if they resume it, it can get better. So it's no harm, no foul, but they've lost some time, and they still need to ramp up, if you will, in terms of their improvement in their symptoms, because sometimes the insurance companies say, no, we're not going to fund this anymore. And then you got to fight with them. And then it takes a few months or even longer. But this is something that is looking to be far more common than we realize in individuals, basically with the mild TBIs. Next slide, please. Okay, and so you have peripheral fatigue. You're running marathons, your muscles are tired, and then you have central fatigue. And central fatigue is like when, probably at the end of this talk, you're exhausted, although you've been sitting in a chair this whole time. So that's the central fatigue, and that appears to be the issue in the fatigue following traumatic brain injury. Peripheral fatigue, rest, sleep, that'll make it better. Central fatigue, not necessarily so. Next slide, please. Okay. Yeah, okay. I pretty much covered the slide. Next slide, please. And here are the complaints. They can't go to back. They can't work. They are truly the walking wounded. A guy that I'm very close to had a soccer injury, but he was watching a game but wasn't paying attention. He got hit in the head with the ball, saw stars, proverbial stars, and then a couple months later just started feeling fatigued, and he said he was thinking about selling his business because he just couldn't function. He said, I could make it to the couch at the end of the day, but then that's it. And this is the kind of guy who'd sell his children before he would sell his business. And he contacted me, and because he had gone to an endocrinologist, and they said, well, your testosterone level is low, because they didn't test for growth hormone. And so they gave him testosterone, and it didn't make a difference. Gave him more testosterone, it didn't make a difference. Uh, Contacted us and came down to Galveston, and he flunked the stimulation test and was put back on growth hormone, and fine, absolutely positively fine. But it's that kind of fatigue, and it's that kind of brain fog. Next slide, please. And so this is a study we did on Biofac, and you can see the numbers. Um, and what we also did was collect fecal samples, which we'll talk about a little bit. Next slide, please. All right. And what we found was that by replacing the growth hormone, you actually can change the morphology of the brain. So something is changing within the brain when we give growth hormone. Now, there is debate about, again, we're back to the stimulation test and what the numbers are, because there are people who are 3.5, 5, 8, which does not meet the qualification insurance-wise, but they're symptomatic, and you give them growth hormone, and their symptoms get better. And you say, well, maybe this is placebo. You have to give yourself a shot every day, and it becomes an impediment to an independent lifestyle. But it's not a placebo response. I guess somebody does, but this isn't a placebo response. Actually, something is changing within the brain when they get growth hormone. Unfortunately, you stop it, their symptoms come back. So are they growth hormone deficient, or is it that growth hormone is the medication that helps your symptoms get better? If I have a tension headache and I take Tylenol and I get better, does it mean I have a Tylenol deficiency, or the Tylenol just simply was the medication that treated the problem? We don't know yet. We don't know. So it may not really be these folks are growth hormone deficient. It may be that growth hormone simply fixes it. Big problem with growth hormone is very, very expensive. It has to be given in a shot. Insurance companies do not like this. They will fight and do everything they can to avoid paying for it, which really makes me wonder if it was, $1 a day, how many people would benefit from the growth hormone pill if it was $1 a day. It's a protein, and you can't take it in a pill because your stomach will just chew it all up, destroy it. So it can't be taken in a pill. But if they had a pill, that might change things significantly. Next slide, please. And we wouldn't be spending so much time fighting with insurance companies. Next slide, please. So this was a study that we did, and we really found there was not a significant change in these aspects in these individuals. So their fat didn't change, their lean body mass really didn't change much either. Next slide, please. But symptomatically, they improved, and these are subjective measures, and they felt that they were better, significantly better, when they received the active medication. Again, I don't think this was this was a placebo-controlled study, so this was the real deal. Next slide, please. Okay, and so maybe what it says, if you could read it, it says maybe it's all about bugs. All right, next slide, please. So you are covered by bacteria. You're in you, on you, all over you. Okay? About 3.5 pounds of your weight is bacteria. Okay, and they are essential for life. You got to have them. Next slide, please. Next one. Yeah. Okay. So I'm going to try to make this as simple as can, because one of the reasons is the slides. You send slides to somebody, and it disappears as it flies through space. Things disappear. But what we found was the microbiome. So we analyzed the feces of the individuals with the traumatic brain injury, and we analyzed the controls. And what we found there were significant differences between the folks with the brain injuries and the folks with the control. Now, in general, if, let's say, I had a family member who lives in this household and had a brain injury, give or take, our microbiome should be about the same. we're living in the same environment, we're eating the same kinds of foods, exposed to the same kinds of bacteria. So our fecal microbiome should be about the same. But what we found was people with brain injury and the cohorts have different microbiome. Of course, so you say, well, how do we fix this? Let me go to the next slide. All right. This was Bakersfield and Galveston, separated by a long distance. And again, people in the same community, give or take, will have a somewhat similar microbiome. But look at Bakersfield, look at Galveston. These were the TBI. Although they were far apart, they had fairly similar microbiome. Average, and then look at the controls. So what was it about the brain injury that caused the microbiome to change? One person said to me that he felt that, well, people with bad brain injuries, they are going to get a lot of antibiotics, which is true, but in this day and age, just about everybody gets a lot of antibiotics. So never really followed that. And we felt it's something about the brain injury. The brain and the gut have to talk to each other. Next slide, please. This I find very fascinating. What we did was we had germ-free mice. So these mice had no bacteria, and we gave them a little fecal implant of feces from humans who had biofilm. And then you put them on the rotor rod, which is this rod that rotates, and how long can the mice stay on? And what we found was that mice that got the fecal implant fell off sooner. And they had some other thing, the water maze test, some other aspects. They didn't do as well. So by giving this bacteria to the mice, we created a brain injury, which would then lead you to say, well, then what we got to do is give people with brain injuries a normal fecal implant to change their microbiome. That to me, that's the easiest thing to do. Why not? Well, there's all sorts of ethical issues. Whose feces do you give? And the other is there are as many bacteria as there are stars in the sky. So what is the exact composition of bacteria that somebody should get? Nobody's figured that out yet. But we gave these mice a brain injury by changing their microbiome. Next slide, please. So what are the possibilities? We're finishing up here pretty quickly. So what is it about a brain injury that makes it a disease process? And here are some possibilities. Loss of brain reserve capacity. You have lots of extra neurons and you get a brain injury and those neurons have to then take over, but then your reserve is gone. So as those guys die off, there's nobody to take their place. Sort of like in the military, you commit your reserves, something happens to your reserves, you got nobody left. I love the idea of apoptosis, which is cellular suicide. Every cell in our bodies is on a timer, every single one. Best example, when we are in our mother's womb and we're swimming around in the amniotic fluid, our fingers are fused. But as soon as we pop out, the tissue dies and we able to spread our fingers apart because that's the timer. Maybe the brain injury resets the timer, and which is cool because if you could figure out apoptosis, you figured out the secret of life, and then you can make a lot of money or something along that line. Next slide, please. So this is again from the Institute of Medicine, and these are their connecting the dots. You've had a brain injury. What do they think the outcome may be? And they stratify. So this is, yeah, maybe it is limited evidence, and you can read mild TBIs with the development of these issues. Again, maybe not really so sure. All right, next slide, please. Okay, positive association. So I don't think it's bias, and they don't think it's due to chance. And again, the connection between brain injury and the development of these issues. And again, this was from 2009. So we're talking 15, 16 years ago that they came out with this. So you can see the connection. And again, these are the smartest people in the room. These are the real bright guys. All right, next slide, please. And then causal, like that's the fact, Jack. You've had penetrating TBI, you got a great risk of developing seizures, um, premature death, etc. Causal, no question about it. Next slide, please. So, in the United States, well over 100,000 individuals who have a brain injury become significantly disabled. And in the United States, at least 5.3 million, many people think it's much higher number now because this is old data, are disabled due to a traumatic brain injury. So it's a large percentage of people who've had traumatic brain injuries are disabled. And there was a recent study in JAMA looking at, this is a British study. I find it fascinating. It was people 40 to 60 or something like 50 to 70 who said they were perfectly healthy, no problems whatsoever. And they found about, and they, in interviewing them, 25% had a history of mild TBI with loss of consciousness. 25% of people who said they were perfectly fine, which is a large number. A friend of mine said here in the States, they think it's maybe closer to 20%, maybe, but regardless. And those individuals with the mild TBIs with loss of consciousness had abnormalities on their MRI, microhemorrhages, and they, on certain aspects of their neuropsychological testing, they did not do as well as the individuals who didn't have that history. And again, they all felt they were fine. So maybe people who think they're fine, who've had a history of a mild TBI with loss of consciousness, maybe they're not as fine as they think they are. And, you know, if we could address this early on, maybe we could do something about it. So there may be even more people who are disabled in some manner, shape, or form due to their brain injury. So I think as a result of their trauma, they have brain injury disease. Next slide, please. And I think once it is recognized as such, and I think we've made significant movement over the past year, then it will be taught and it will be reimbursed and it'll be managed just like other chronic diseases, because only then are we going to be able to treat the patient with the disease as opposed to the disease in the patient. And then they will get the medical surveillance, the support, and the treatment that they deserve. And then we'll get the research funding, knock on wood, that TBI truly deserves. And then we're going to be able to start talking about a cure. Next slide, please. So I know that you're very fatigued. And like I said, some of you just woke up and just rolled straight into your computer room. So I want to thank you very much for staying awake. Next slide. And I want to thank all my staff that has worked so hard with me. And next slide. And that's it. Thank you very much.
Dr. Masel, thank you so much. Fantastic lecture. Very interesting. Most interesting, your staff, of course, as you well know. But let's open it up for question and answers. Everybody can unmic, or if you want to send over something in the chat function, we can also do the Q&A that way. So preferably, if you can have a chat with us and unmute and ask some questions, that would be great.
I have a question. I know we didn't really get into therapies, but it seems maybe supplementing with some branch chain amino acids might be some low-hanging fruit there to help people as they go through this. Would that be a good conclusion?
There is absolutely no question about this. And I mentioned Rob and I and Kate, we're working on a study where we can give people the IV branch chain amino acids, because that takes out the factor of the gut microbiome, and see if we can extend the improvement. The Italian study, they stopped at, I don't know, 3 weeks or 4 weeks. It was a short period of time, which is great, but it's not 4 weeks after your injury is not the critical thing. It's how are you doing months and months later. The problem is the problem is the microbiome, and that you're not absorbing those branched chain amino acids. That's not going to happen, which is what happened with your bacon and eggs when we did the study. So what we're trying to do is find out if IV can make a difference
Sure.
long term. But you're absolutely, I'm with
Okay,
you 100%.
Brent or Dr. Masel, I'm gonna go back to something that I want
Only
everybody.
my kids, only my kids have to call me doctor.
Yeah. Okay, only your kids. Got it, Brent. Okay, so I want to briefly mention to the group, and not everybody's familiar with sleep medicine. Not everybody's familiar with the multiple latency sleep test, which you mentioned. And so I just want to highlight for everybody that Dr. Masel was talking about a daytime sleep study that is done after the overnight sleep study called the multiple sleep latency test, or MSLT. And that's something that sleep physicians don't always do, but it's very important for documenting both objective hypersomnia as well as post-traumatic narcolepsy. And I would say, Brent, the vast majority of brain injury docs that I talk to, even people that are involved in brain injury, don't know about that test. So we're going to have Gandis Majeka on later this year, who's a board-certified sleep physician, and he's going to be focusing for an entire session on sleep medicine and TBI. So I really appreciate you calling that to our attention. What's been your experience over the years clinically? Because you've been doing this for what, 35, 40 years with excessive daytime sleepiness. Can you talk about that a little bit in your clinical experience?
Sure. Part of the reason they don't do it, it's economic. You tie up the bed, you tie up a technician, so you've doubled the time involved, and of course the cost involved. So that's, I think, part of the reason. But the company I work for, we're doing them now in Dallas. It's in our Dallas program, and it's just free. It's just, we identify people we think might need the test, and it was hard to get everybody on board with doing the sleep latency test. But as I showed in that slide, a huge number of people passed their polysomnogram just fine and dandy, but they flunked the sleep latency test. So they were still sleepy. Finding the right medication, we did a couple of studies, none of them, quite frankly, terribly elegantly done, trying to find the medication. We've looked at modafinil or now Nuvigil, which may be of some benefit, but it's hit or miss. If you have somebody who is clinically sleepy, I think they clearly need to be evaluated for pituitary dysfunction and obviously any other metabolic problem. And then giving them something like Nuvigil or modafinil, it's worth a try. But again, it's expensive, and it's a fight with the insurance company.
Great. Well, I just want everybody to be aware of that. We're scaffolding knowledge here, so you're going to hear a lot of redundancy and then augmentation. So we'll get a full sleep lecture. I think in a couple months, Dr. Majeka will be on to do that lecture as well, and hopefully, Brent, you'll be there as well, so we can get a nice panel or chat going again.
Thank you.
Let's go back, since there's no other questions. Let's go back to Laura. You got another question for
No, I have a question, Davis.
Oh, Dr. Yuen, please, Dr.
Hey, Brent, nice to see you. So,
hey, Kevin.
Talking about the sleep aspect of it, so when you looked at the patients that were treated with growth hormone, did you see any, and you said obviously it helped with the fatigue, but how did it impact? And if so, which aspects of the sleep did it impact, if any at all, with the growth hormone therapy?
I'm not aware if we asked them about that. Kate Randolph, who's the base of our pyramid in our research group. Kate, do you know?
Yeah, we do the Pittsburgh Sleep Quality Index on all our growth hormone patients. We do have that data broken out by the different aspects of that test. I'd have to pull that and look. We do have that, though, broken out into like components, different components.
Yeah, let me chime in.
They do get better. The PSQI does show improvement quite quickly, actually.
Yeah. So the PSQI is more a study of sleep, whereas for daytime sleepiness, the gold standard is the Epworth Sleepiness Scale. And I use that at my facility. We're starting to look at some retrospective data on that. We've got that in our next study, Kevin, on growth hormone that we're trying to raise money for right now. So we'll be looking at the subjective hypersomnia, daytime sleepiness. And then we're hoping also to start doing sleep studies with the growth hormone intervention. So if we can get some objective data with the daytime sleep study, the multiple sleep latency test, to see if the growth hormone is affecting objective measures, essentially.
Because I think these it would be nice to see which aspects of the sleep that it helps, because presumably, and the growth hormone that you studied were administered daily, because now with the advent of the long-acting growth hormone and the different PK/PD aspects of the long-acting, you might possibly see some changes because of the different mechanism. Because when you give it daily, you probably might see the effects it has on different components of sleep, but then maybe there may be differences in the long-acting. So I'm curious to see if there's any differences treating these TBI patients between the daily versus the long-acting.
Yeah,
Kate, I guess we ought to look deeper into this. We ought to pull that stuff out.
I think part of it is, part of the intention of this group was to bring physicians, other researchers together from different disciplines to create this kind of crosstalk. Because what I noticed when I moved into multidisciplinary TBI work, I had the privilege of working with like 6 different disciplines and realized that everybody was operating in silos. So I would talk to an endocrinologist. They didn't know much about MSLT, sleep testing in the daytime. They'd heard of polysomnography, but they weren't necessarily talking to sleep physicians. And so part of this is to create a research collaboration where we come up with new ideas. I think we should be using polysomnography as well as daytime sleep testing when we're doing growth hormone studies, because the real question with the polysomnography will help you look at the sleep architecture, right? And we know that growth hormone promotes increased stage 3 sleep, so delta waves essentially. And when you get reduced delta waves, you also have less growth hormone secretion. But nobody's really studying this, so hopefully we can get this funding, and Brent, Kevin, everybody I know is publishing together and start to bring sleep medicine in to our next studies. So I think it's a great idea, Kevin. We definitely need more of this for sure. Anything else from Dr. Yuen? Any other comments?
I had a question, if Dr. Yuen is done.
Yeah, Richard, Dr. Sarusi here, PM&R.
Are you done, Dr. Yuen?
Yeah, go ahead, Richard.
I have a very basic question. We commonly recommend fish oil, for example, after TBI. And I guess one mechanism might be that we're thinking of reducing neuroinflammation, but do you have any more in-depth understanding, anyone here really, but also to Brent, of why that might be true? What's the mechanism?
I have no idea. I could make up something, but I have no idea.
No, that's okay. No, it's very interesting. And by the way, a great talk. Very, very interesting. Thank you.
Okay, great. Anybody else have questions before we throw the hot potato back to Laura? Laura, you want to just jump in and go ahead?
Well, following up on Dr. Yuen, I'm curious, are we always only seeing diminished growth hormone, or is it also potentially dysregulation and an excess of growth hormone that could potentially happen?
Is that question for Dr. Yuen?
Well, whoever, like.
Oh, well, look, yeah.
He's probably the guy to ask.
Dr. Yuen is chief of the guidelines, been around. It's great to have Dr. Yuen here today. So I think let's pass that over to Dr. Yuen to answer.
I think all the above. We still don't quite know exactly the mechanics of growth hormone secretion in these patients, and it's very difficult to study these patients, especially when you have so many other factors ongoing. They're in pain, their sleep is dysregulated. They, as Brent said, perhaps their food intake, their nutrition. There's so many factors which growth hormone is reliant upon for its diurnal secretion. So, yeah, it's difficult. I'm actually not sure how we can actually untangle this maze here, because there's so many covariants here that are actually playing into this problem with growth hormone secretion. But potentially, I suspect it's a combination of dysregulation, insufficiency, and also the effects it has on other parts of the brain function.
Okay.
Yeah. So I think Laura, there's not today we're sort of privileged to have Dr. Yuen and Dr. Masel here. I mean, they're sort of they basically, these two along with Randall Urban helped to sort of discover what we call post-traumatic hypopituitarism and really develop the research. We don't see growth hormone excess so far in brain injury. We're not getting a kind of, acromegaly or excessive growth hormone. But what we don't know a lot about is this, what we call the secretory dynamics, because we only have a stimulation test. But the most well-characterized growth hormone abnormality is growth hormone deficiency. Then BIOFAC is sort of an outgrowth of that that's sort of been mostly exclusively studied at University of Texas Medical Branch. Dr. Masel's part of that group. Dr. Yuen comes in as well. Dr. Urban, I'm also part of that group. Rob Dickerman as well. But what we just don't know enough about the changes in growth hormone dynamics, because we can't study that over a 24-hour period, because you got to take hundreds of blood samples to figure that out. And it's just not really feasible in the research or clinical setting, very cumbersome.
Okay, so then my other question for Brent is the endocrine connection. And I recall you said that post TBI, there can be a loss of menstrual cycle. And I am still trying to find someone who can answer this question for me, again, based on personal experience. Someone who developed post-traumatic epilepsy every second menstrual cycle. And I can't find anyone who can help me with that. And the best guess I've come up with is alternating anovulatory cycles. But then was it the ovulatory or the anovulatory cycle? But still, we're going back now to endocrine system. And I'm having difficulty finding like people, like you say, cross-trained in.
Well, catamenial epilepsy is well known, and it's not at all uncommon. Factor out brain injury for women to have seizures and migraines too, by the way, at a certain point in their cycle. And women are different. All women are different. I mean, it's not like it's going to be right before their menses or right after. It's somewhere, because, as you know, it's a dynamic of multiple hormone, progesterone, estrogen. So it's well known. And again, it's not a specific aspect. Okay. So the answer is we don't know. But what you described is quite common.
Well, sorry, go ahead.
Yeah, I think just to get some basic sort of conversation going on between endocrinology and neurology, which is the domain, neurologists deal with seizure disorders. So estrogen is known to lower seizure thresholds, and progesterone is known to raise seizure thresholds. So with those two things and with those two facts in mind, you can sort of think about that in kind of, trying to figure out what's going on with your daughter and doing some lab testing. But, there's also some epidemiology, as you know, Dr. Masel, that postmenopausal women may have lower frequency of seizures after they go through menopause and the estrogen goes down. There's a condition that's well recognized within endocrinology. Dr. Masel talked about it today. It's hypogonadotropic hypogonadism, where you lose pituitary signaling from luteinizing hormone and follicle stimulating hormone. And in a male, the testosterone goes down, and in a female, the estrogen goes down. And Brent, you're making me wonder if that's a protective mechanism against seizures. You were talking about potential protective mechanisms. Most of the females that I work with recover from that, meaning we'll see the first year or so, they may have the menstrual irregularities and the hypogonadism, and then they recover. But Dr. Yuen has more experience than any of us with this. So I would be curious, Dr. Yuen, in your experience, what's your experience with women that develop post-traumatic hypogonadism and then recover from it? Do you see a frequent recovery or prolonged permanent secondary hypogonadism in the females with TBI?
I actually don't. I mean, you would expect, if you follow them long enough, you would. But then again, also, a lot of these women can be put on OCPs, which actually mask the whole thing. So which makes understanding the trajectory of this hypopituitarism a little bit more difficult to quantify. So short answer is I have not seen as many as I thought I would. But then again, it's, the data could be muddied by the fact that these women could be on OCPs because of that as well.
Yeah, I mean, I would agree with you, Dr. Yuen. I mean, you and I and Brent and Randy and Kate and everybody, we published we had about 126 cases of, we had very few in the chronic phase. And again, that was about 75% mild TBI. We had very few women with prolonged hypogonadism, very, very few.
Yeah.
And it's much higher in the literature because, when I was doing my dissertation work on it, it was pretty high. I mean, it was like 12%, 1 in 10. And I just have not seen that in clinical practice at all. But that's true with central adrenal insufficiency as well in the long run. So I'm not sure about that. But Laura, any other questions that you had?
No, thank you for the discussion, and I'm already taking practical things from the lecture that you gave to look at applying and do my little N of 1 experimentation on my family. Get back to you with my research.
Got it.
Great.
Doctor, just to get the chemistry done for today, Dr. Parker wanted to mention that progesterone converts to allopregnanolone, and it's the allopregnanolone metabolite that decreases the tendency for epilepsy rather than the progesterone. That's actually my wife correcting my biochemistry for everybody. So she keeps me sharp.
Way to go, wife.
She specializes in female hormones and the menopausal transition. And she lets me know, of course, estrogen is neuroexcitatory. Okay. So
have her call me.
Dr. Parker. And she also told me that the allopregnanolone has been shown to lower high beta wave activity on EEG. So thank you, Dr. Parker, for augmenting it. We always say our better half. I know we all have one of those. I've got one of those as well. So I appreciate everybody being here today and all the contributions. We had a lot of stragglers coming out, but this has been recorded and we'll get it posted up. Dr. Masel, thank you, Brent, for the generosity of your time today. It was great to have everybody here.
Thank you.
Bye.
It's a pleasure.
Take care, everybody.
And if anybody has any questions, Davis knows how to get a hold of me.
Absolutely. Yeah.
Thank you so much again.
And Brent, what I'll do, I'll also post some of the papers as well, so that people that you mentioned, that way people have access to those full texts as well.
Sure. Great.
Thanks again.
Great.
Take care.
All right. Bye-bye.